Hello friends, today we are discussing a highly interesting and challenging case involving a large retained glass foreign body in the wrist. The patient presented to our emergency department after punching a mirror in the anger. On initial inspection, we noted a sharp wedge-shaped piece of a glass projecting directly through the skin on the radial aspect of the wrist. However, it was the X-ray that gave us a true surprise. The imaging revealed an unexpectedly massive piece of glass extending deep and distal to Thenar eminence. We immediately shifted the patient to the operating room. The tourniquet was placed on the arm but left uninflated, allowing us to monitor the vascularity. Thankfully, on clinical assessment, radial artery was still intact. Our surgical approach began by evacuating the hematoma around the entry site. Then we extended the incision longitudinally along the radial side, taking meticulous care to isolate and protect the radial artery. Because the glass was firmly wedged in the deep tissue, we utilized careful blunt dissection around its margin. By combining peripheral dissection with the release of deep clot, 12 by 4 cm square size glass piece was safely removed. Following the removal of foreign body, we performed copious wound lavage. This was cleared away the tamponating clots, exposing a lacerated vessel that immediately begins to bleed. The bleeding vessel were quickly identified, isolated and controlled with cautery. Once stable hemostasis was achieved, we systematically explored the wound for deeper structural damage. We located the proximal stump of injured tendon. By carefully exploring distally, we retrieved the corresponding distal segment. To verify the anatomy, we gently tensioned the distal segment, confirming it to be the flexor pollicis longus tendon. Both stumps were then mobilized and prepared for formal repair. To restore continuity, we use modified Kessler technique, which is gold standard for robust core tendon repairs. First, the needle is inserted directly into the exposed cord stump, traveling longitudinally for 1 cm before exiting through the outer epitendon. Then the needle is reinserted transversely across the tendon to exit on the opposite side. A reverse longitudinal bite is then taken, bringing the needle back out through the face of the cord stump. And then This identical pattern is repeated on the opposing tendon stump as well. The two trailing suture ends are then tensioned to perfectly approximate the tendinase and secured with surgeon's knot. While the core suture provides the bulk of our tensile strength, I prefer to add few running epitendinous suture bites at the surface. This ensures neat alignment of the tendon fiber as well as provide crucial structural stability. After a final thorough irrigation, the wound was closed in layers. The wrist and thumb were immobilized in thumb spica slab, keeping the thumb in relaxed flexed position to minimize the tension in our repair. Our post-operative protocol relies on early intermittent passive mobilization to prevent dense adhesion, while delaying the formal active mobilization until 6 weeks to allow biological repair to fully mature. Thank you for watching the video. See you in next video.